Okay guys, welcome to another episode of Learning on Smartnursing, and today we want to talk about atherosclerosis. Okay, so without wasting much time, let's just get right into it. So what is atherosclerosis? Basically, it's an inflammatory disease. So it's a chronic inflammatory disease. Atherosclerosis is a chronic inflammatory disease. What that means is that there's an inflammation process going on gradually, and then it worsens, okay, inside your blood vessels, most especially the arteries. All right, so when you look at the name, we have athero and then we have sclerosis. So basically, athero is for arteries, sclerosis is like narrowing, so narrowing of the arteries. Okay, now what happens usually when there is chronic inflammation? This is characterized by the accumulation of lipids, cholesterol, calcium, okay, inside the intima of the arteries, okay, and then this leads to atheromatoous plaques, which causes narrowing of the arteries. All right, so basically there's an inflammation process ongoing that has led to the accumulation of lipids, accumulation of calcium, accumulation of cholesterol inside the intima of the blood vessels. Now this goes on for a while, a plaque forms, and then it leads to narrowing. Now this plaque, the fact that it is there and it has narrowed the lumen of the arteries or the blood vessels, can also lead to reduced blood supply to wherever that artery is supplying, and then cause ischemia, or in another form, if that plaque ruptures, then bleeding, then there will be activation of platelet, there's going to be clot formation, and then that clot can go and cause an emboli somewhere. So now let's look at the pathophysiology of atherosclerosis. Let's look at the pathophysiology. Usually, it takes 6 stages. All right, there are 6 stages in this pathophysiology. There's going to be endothelial injury. There's going to be endothelial dysfunction. This will lead to lipoprotein entry and then oxidation. This will now lead to monocyte adhesion and foam cell formation. Inflammatory response and cytokine release follows. And there is smooth muscle cell proliferation, and then fibrous, cap formation. After that, you will have a plaque progression, which usually leads to a complication. So how can we put all this together? The arteries have 3 layers, all right? So you're going to have the tunica externa outside, okay? So let's assume this is a tunica externa, all right? Then you're going to have your tunica media over here. That is usually the medial layer, which is made up of smooth muscle cells, all right? We will see how that plays out in the atherosclerosis formation. Then we have the inner layer, which is known as the intima, okay? So that is a tunica intima. All right, so for atherosclerosis to happen, there have to be an injury or a damage to this endothelium over here. Now when this get damaged, then there's going to be leakage. As this leaks and it's exposed, it's going to generate inflammatory responses. You are going to have inflammatory mediators coming into here. Your cytokines will come, your monocytes will come, your T lymphocytes, your tissue necrosis factors, all those things are going to come here. Now when they come, they will activate more and more inflammatory response. So you realize that after your endothelial injury, there's endothelial dysfunction, in the sense that because there's a damage here, the artery will not function as it's supposed to. Okay, so what will happen is that you're going to have your nitrous oxide being lost. Nitrous oxide inside the artery will be lost. Why? Because the inflammatory response that this injury has, initiated here is going to attract monocytes, it's going to attract lymphocytes. These monocytes and lymphocytes coming in are going to lead to loss of nitrous oxide. And obviously, this will progress to loss of vasodilation. So, no nitrous oxide, no vasodilation. So already, your artery is beginning to dysfunction at this point. It cannot dilate where it's supposed to. So blood supply will be reduced gradually, okay? It won't dilate when it has to dilate in case you need more blood supply. Probably in some impending shock situation, that will not happen. All right. Now, the damage that has already been caused here is going to cause what we call LDL, or the bad cholesterol. We have the good cholesterol, we have the bad cholesterol. Now the bad cholesterol, the LDL, will now find its way into the intima because there is space here. Okay, it will get here, it will get oxidized, and then it will become what we call oxidized LDL, which is also a highly inflammatory, attraction material, which is going to lead to more inflammatory process and more immune cells coming together. Now, when this oxidized LDL gets here, it's going to trigger monocytes into the intima, okay, because there has been space here, the LDL has penetrated, it's now here, it is oxidized, then it will now become a fertile ground attracting monocytes. Now these monocytes get here, they get differentiated into macrophages, and we already know what macrophages can do. The monocytes will enter into the intima, they get differentiated into macrophages, and now these macrophages will now come and engulf the oxidized LDL over here. Okay, let's just start. We had a healthy arterial wall, okay, then it got damaged. The intima gets damaged, then it's attracting LDL. Before that, it has led to a lot of inflammatory responses. Then nitrous oxide was lost and there was no vasodilation anymore. Aside that, LDL has penetrated and gets oxidized and becomes oxidized LDL. After that, the oxidized LDL is also a highly inflammatory material, attracting more and more inflammatory mediators. So monocytes have come in, and as they entered into the oxidized LDL, they have differentiated into macrophages. Now these macrophages then will now engulf the oxidized LDL over here. As they engulf this oxidized LDL, they begin to form what we call fatty streaks. They form fatty streaks, and so they will now be forming streaks like this, streaks like this, streaks like this. And then this streaks is what you actually see the earliest. That is the first thing you see when you do an imaging. Okay, you do an imaging into the arteries, you will see this fatty streaks over here, and that is what you see as atherosclerosis formation. But then by the time it gets here, a lot of damage have gone already. Okay, so as these fatty cells get here, now more inflammatory response is triggered. Okay, it's just like having a wound on the surface of your skin. You realize that before this wound will heal, you're going to see inflammation first. The tissues around will get inflamed because the body is releasing the inflammatory mediators, it is releasing the the soldiers that he thinks or she thinks can cure that wound. And that is what triggers your inflammatory response. It's basically the same philosophy over here. As the vessels get damaged, it becomes a wound, and so inflammatory response is triggered. Now, as it goes on, more and more inflammatory response, basically, like we said, it's actually a chronic inflammatory disease. So it's more of inflammation and more of inflammation. So as this fatty streak gets here, inflammatory response comes in again. Now there's going to be cytokine release, tissue necrosis factors, interleukin 1, we're going to have the macrophages. They all come together once more, still on this fatty streak. When they get here, they are amplifying the inflammation. They try to work, and as they work, they release more substances that worsens the inflammation. Now remember, we said that the vessel is made up of 3 layers. We have the externa, the tunica externa, we have the tunica media, and we have the tunica intima. Now smooth muscles will now migrate from the media into the intima. Smooth muscle cells will now migrate from here into here. Okay, as they get there, they will now secrete some proteins, okay, out of the muscles. They're going to receive some secretion of proteins like collagen, elastin, which are, fibrous or fibrogenous proteins. This collagen or this elastin will now form a fibrous cap over the lipid core. Okay, so the fatty streaks that have accumulated here are usually lipids, and they are not stable enough, they are not hard enough. So these smooth muscles from the media will now come here and now form a covering. They will now form a fibrous cap around these fatty streaks here in a bit to stabilize them. That is why you see that most people might be moving around with atheromatous plaques inside their arteries, but then it is being capsulated, it is being stabilized, it is being covered by this fibrous cap. So the body has its own way of protecting itself. It still wants to maintain the homeostasis, okay, but for how long? All right, so usually when we talk about atherosclerosis, we have the inner one, that is the lipid core, okay, which is referred to as the atheroma. All right, then we have the outside one, which is the hard fibrous core, fibrous cap, which is the fibroateroma. Okay, so the smooth muscles migrating from the media here come into the intima, form the covering around it in a bit to stabilize it. Okay, but as the inflammation progresses, it ruptures, and that is where the problem comes. Like I said, even if it doesn't rupture, the narrowing alone causes significant damage because there is reduced blood supply to whatever area those arteries are supplying. Okay, when it gets here, like I said already, we can have a stable one or we can have a non-stable one. A stable one is the one that has a very thick covering, a very thick fibrous covering, and it's just a small lipid core. Okay, that's a very stable one. It's the fibrous covering is hard enough, so it will be very difficult for this plaque to rupture. Okay, but then a vulnerable or an unstable one is the one that has a thin fibrous cap and a very thick core. Okay, these are the 2 types we have, and depending on whichever one is the problem, then your complications ensure from there. But what happens when a plaque ruptures? So when a plaque ruptures, like I said, it's like having a growth on your skin and it has been scrubbed off. So wherever it was attached to becomes a wound. There's going to be bleeding. Now that exposed area over there is going to release substances into the blood system that is going to trigger platelet and then clot formation. So anytime a plaque ruptures the exposed area to the bloodstream, releasing tissue factors into the bloodstream. Now this is going to lead to platelet activation and thrombus formation. So there's going to be a lot of clot formation anytime a plaque ruptures. Now the danger here is that any clot that travels and gets lodged into a place where it is not supposed to be is going to cause a problem. So for example, if it goes into your coronary system, you're going to have what we call acute coronary syndrome. And watch out for the video where we discuss acute coronary syndrome into details. Okay, so if a plaque ruptures and gets into your coronary system, then you're going to have acute coronary syndrome, where we have our unstable angina, our NSTEMI or our non-ST elevation myocardial infarction, and then our STEMI, which is ST elevation myocardial infarction. Okay, so now if it gets into your carotid arteries, then you're going to have a CVA or a cerebrovascular accident, or what we simply call stroke. Now if it gets to your peripheral arteries, then you're going to have a peripheral artery disease, that is to your legs. Then if you get to your pulmonary system, you're going to have a pulmonary embolism. Okay, so we do not want this to get here, and all this means that preventing the formation of this plaque will solve a lot of problems or go a great deal to help. So what are some of the risk factors? Risk factors are usually grouped into two: the modifiable and the non-modifiable. Okay, so the modifiable ones are the ones that you can obviously do something about, like hypertension, diabetes, smoking, dyslipidemia. You can always do something about them. You can take statins for your lipids, you can take your antihypertensives, you can exercise, you can stop smoking, you can do a glycemic control by taking your anti-diabetics. So this you can do something about. But the non-modifiable ones are the ones you cannot control. The fact that you're aging, the fact that you are a male, the fact that you have a family history or a genetics history of atherosclerosis, there is nothing you can do about that. But we always encourage that the ones that you can do something about, make sure you do that. Okay, so how do we prevent it? Obviously, we want to prevent it, then we want to look at our lifestyle. Okay, let's eat healthy, low saturated fats, and then high fiber diet. We already know the role fiber can play already. So you need low saturated fats, you need high fiber diet. Eat healthy. Regular exercises, smoke cessation, weight management, all goes a great deal to help. For medications, you take your statins when you are diagnosed of, dyslipidemia. This will stabilize your pulse. Antihypertensives like ACE inhibitors, antiplatelets like aspirin, glycemic control in diabetes, all, like I said earlier, goes a great deal to, take care of the modifiable risk factors. Now, in case of procedures, when necessary, they can do an angioplasty for you. An angioplasty simply means they go inside the lumen and then try to patch up the damages. Okay, and then coronary bypass graft if possible. Okay, so basically we've been talking about atherosclerosis. We said it is a chronic inflammatory disease, characterized by accumulation of lipids, cholesterol, calcium, and all that. At the end of the day, there's going to be narrowing of your lumen. Then we spoke about how it happens. That usually you're going to have an endothelial injury, which is going to cause a lot of inflammation. Now this inflammation is actually the basis for all this. The damage is going to open up lipid, or the LDL will come in, will get oxidized. Monocytes will come in, differentiate into macrophages. The macrophages will now engulf the oxidized LDL, now forming foam cells, which will now lead to fatty streaks. Okay, now when these fatty streaks are forming, they accumulate in your arteries. Then the smooth muscles from the media of the vessel will migrate into the intima in an attempt to stabilize the arterial streaks that have formed. So they will form a fibrous cap around it. Now, if they are able to grow thick enough and they stabilize that atheroma, then it won't rupture. That is what we call a stable, atheroma. But then if the capsules or the fibrous covering is very thin, then it will lead to a rupture with the least provocation. So basically, this is what atherosclerosis is. This has been Smart Nursing, and we will see you in another video.